I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel Friends. We're here because everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Today's topic is treat 'em and street 'em, the dangers of instant gratification in healthcare. Robert has had back-to-back meetings and will be joining us in a few minutes. But in the meanwhile, let me introduce Dr. Dan McCarter. Dr. Dan, how are you doing?
I'm good, Faisel. How are you?
I'm doing great. It's just another one of those weeks where every day feels like a week. So
That's right.
I look forward to these minutes that we have that we can get together and just talk shop about issues in healthcare, especially so far as primary care is concerned, with prevention and early intervention.
Exactly. And I think this is a great topic, and looking forward to dealing with the chat and the questions tonight, and just would invite anybody that has questions to put them in the chat, and we'll get them in front of you and the rest of the speakers this evening.
Excellent. Thank you so much, Dr. Dan. And without further ado, our guest this week, who is more a friend than a guest, which is, I guess, why we call it Faisel and Friends and not Faisel and Guests, is Dr. Ajoy Kumar. Dr. Ajoy, thank you so much for coming.
Thank you, Faisel. Thank you for having me. Thank you, Dr. Dan. Really appreciate you both. And, basically all the things that you guys are doing to help advance primary care medicine. I agree with you wholeheartedly. I think everybody deserves a physician, a primary care physician, regardless of the inability to pay. I think that's super important. Relationships matter. And what we do in primary care to build those relationships, to continue those relationships, matter.
Yeah, it's a sacred relationship. It used to be a sacred one before it became the financial one that everyone knows today. Mm-hmm. So let's get into the topic for this week. So the topic with instant gratification, the dangers of instant gratification in healthcare, kind of goes to the fact that half of all medical care in the country today is delivered in the emergency room setting, at least pre-COVID. But that tells you something's majorly wrong with this system. And we all know that the vast majority of care that's delivered in the emergency room setting can be done easily in the primary care or the outpatient setting. Now, Dr. Ajoy, you worked in the emergency room. You had a history working in the ER or in the hospital.
Yeah, that's correct. This hits particularly personal to me, having worked in the emergency room and covered a whole emergency room as well as the hospital by myself at night times. I can tell you there is a significant amount of overutilization, people utilizing the ER way too often for things that can truly be done in the primary care's office. And I can tell you, even from personal experience, that from the cases that I saw that came through my ER when I was on, I would have to say 85% of cases could have really been managed in the primary care's office. You ask, why do people go to the emergency department in urgent care? Well, 2017, Journal of Academic Emergency Medicine did an article that said, why do people choose emergency and urgent care services? And it was a rapid review utilizing systematic literature search and narrative synthesis. And what they identified, which is pretty common, is they identified 6 reasons explaining why patients choose to access emergency and urgent care services for mainly low urgency health problems. They include limited access to or confidence in primary care, patient perceived urgencies, convenience, views of family and friends and other health officials, and the belief that their condition required the resources and facilities offered by a particular healthcare provider. And last but not least, I put number 7, healthcare disparities and inequity. So there are a myriad of reasons why people utilize these things and why we need to kind of redirect that care back to where it truly belongs, which is primary care. And I think companies such as the ones that we work for, ChenMed, do such a fantastic job of managing those cases that should be managed in the primary care setting versus sending them to the ER. And especially in the age of COVID, we really need to decompress our ERs and help out our ER colleagues by not overburdening an already overburdened system.
Well, but the thing is that when I think about the vast majority of the people going to the emergency room setting, do you think that they'd go to the emergency room if they had access to a good primary care delivery system? And I'm not just talking just even nurse practitioners, PAs, just a primary care system that was there for people for early intervention.
So I'll tell you, having spoken to plenty of people in the ER as to why they decided to come to the ER late at night or 3 o'clock in the morning versus waiting the next day, it really became an issue of access. I can't get into my primary care physician's office because it takes 2 months, 3 months to get in there. It's hard to get in there because I need to be a new patient. I have to pay a copay. There's so many reasons, almost roadblocks that we put up there, or the system of care that we currently practice under, the fee-for-service system puts up in front of individuals to get that care that they need. And this is even more troubling, especially when you talk about populations that are most risk.
I think I can't. One of the things that bothered me the most when I left from full scope family practice to this geriatric care. We work at ChenMed. ChenMed is a geriatric practice. Our average patient is 72, 74 years old. I think one of the things that disturbed me the most was learning about how many insulin-dependent diabetics didn't need to be on insulin in the first place. And they were on insulin for like 10, 20 plus years because they had a hyperglycemic episode in the ER. They were prescribed insulin to take care of the situation. And then for decades, they're just refilled insulin until they come to they'll become eligible for a Medicare Advantage. And then we'll see them and we get to spend some time with them. And I was just blown away. They thought I was God's gift to medicine because I'm weaning them off of insulin and trying oral meds and lifestyle. But I just wonder how much care in the country right now is delivered so inefficiently because it was just quick fixes. Right.
I'll tell you exactly. Actually, I have a study here from the emergency department utilization numbers from the American College of Emergency Physicians. And what they put together was a study called the National Hospital Ambulatory Medical Care Survey. And that's usually done through the CDC. And these are 2016 numbers from it. But what it said is basically there was 145.6 million individuals that visited the ED, the emergency department, in 2016 versus 107.5 million people that did so in 2001. That's a 38 million person increase, or a 26% increase in emergency room utilization. Now, other data shows the high utilizers tend to include infants, nursing home residents, homeless, Black persons, and people over age 75. You go talk about even specific numbers. There was persons over age 65 accounted by 15.8% of all emergency department visits, and persons age 75 and older had 605 visits per 1,000 in 2016. The leading causes of injury, poisoning, and adverse effects related to ED visits were falls and motor vehicle accidents. And who had the majority of falls? People over age 65. Other more frequent items tended to be stomach pain and abdominal pain were the most frequent, followed by chest pain and mental illness. And as of 2018, the Urgent Care Association counts 8,285 urgent care centers, amounting to 89 million visits in an $18 billion industry. I mean, It's really phenomenal, the amount of care that is being provided at those areas. And I'm not saying it's not unneeded care. It is definitely needed care. In fact, there are times where people have to come in and I have to do an emergency medical evaluation to see whether or not they meet emergency criteria. And if they don't, I would have to often refer those people back to a primary care physician or refer them to a new primary care physician, sitting there saying basically, listen, you don't have an emergency issue at this point in time by my evaluation, but you do need care. And this
Oh, I think we just lost Dr. Kumar.
Oh, okay. Okay. Well, there are a couple of interesting comments here, so I will throw it out to you, Faisel.
there we go. Sorry about that. No, what I was saying, most primary care physicians' offices, what tends to happen is that they have over 3,000 patients per each physician. And that there is a huge problem. If I'm a primary care physician and I got 3,000 patients in my patient panel, how readily can I get in a new patient that needs that urgent care? It's hard to. So we have some structural inefficiencies that we're facing in healthcare in the United States. And if we don't address those structural cases, which are tied to economic issues, we're not going to make much movement in these things.
Yeah, the system is so clunky and so difficult. But I wonder why that is. I mean, when you're talking about 3,000 patients for one doctor, I mean, first of all, that's just, obviously, it's a ridiculous number. I mean, that is just an completely unrealistic, ridiculous number. Where primary care ends up turning into urgent care, where the primary care doctors don't even have time to look into the causes of the causes. It just turns into urgent care sort of, treat them and just keep moving.
I will tell you what I was told when I was going and working in the ER. In order for me to make my metrics, I had to see roughly 25 patients in a shift, in a 12-hour shift. So I am hustling through patients as quickly as I possibly can. If they get admitted, I admit them quickly. If they don't meet anything, they get treated and treated. That's exactly how you do. And what you try to do is try to provide the greatest amount of care for the greatest amount of people, not necessarily the highest quality of care. You're trying to keep pace with what's going on, and it makes it very, very hard. And it makes it very, very stressful for a lot of the folks that practice emergency medicine, because there's so much that's placed on them to not only manage the non-acute cases, but also the acute cases, but they all have to manage all these things in the same way.
Right. And they're being held accountable for keeping everybody happy as well. So no, there's some interesting comments going on here. Melanie Glick said, I fear doctors will prefer telemedicine over in-office once COVID is over and under control. What are your thoughts? But let me just read a couple of these other comments because I think they fit together nicely.
Yeah.
Sandy Weiss.
Melanie.
Sandy Weiss mentions, until the community has easy and inexpensive access to healthcare, people will use the ED for basic care. Thanks for shedding light on this topic. And then John Bender, who's a family doctor,
That's right.
doing direct primary care,
Awesome.
says my DPC patients love telehealth with me. Why would they pay for telehealth elsewhere when they have already subscribed to me? And why do they come to why they come to me instead of going to the ER? So, I mean, it's interesting. You're talking about affordable care. You're talking about direct primary care. I don't know how much Dr. Bender charges per month, but I know we see DPC docs that'll often allow a subscription for $70 a month compared to the thousands of dollars that it costs somebody anytime a patient goes to the emergency room. So I just wonder what you all think about those comments about affordable care being a cure to the emergency room.
So here's my thought points on this. And it's actually interesting because having been at Capitol Hill and at our local state capitol, doing quite a bit of lobbying, Dr. Bender's there too. I mean, I've worked with him before at the American Academy of Family Physicians, no doubt, is that we want to increase access to care for all our patients. How do we increase access to care? Well, you have to be available. You have to have an opening. You have to have slots available, and they have to be affordable, because many of our patients, they're low income to no income. How do they come up with that? And on top of that, how do you get them in? Because most of these folks work 2-3 jobs. So they don't show up for a job, they're losing money. They can't take care of their family. So all these economic factors in the background, plus our scheduling issues, it becomes quite interesting in how we do that. Now, DPC is a wonderful model, absolutely wonderful model too. We have one, value-based care. then you have fee for service. So there's different ways of doing this, but the bottom line is, how do we get more patients coming through to the primary care physician's office instead of the urgent care or overburdening the already overburdened emergency department system? And I don't think there's any one single way of doing it. And I don't think there's only one single partner that we have to work with. I think we have to truly utilize all our resources, work in collaboratives to really address this issue.
So I'm going to jump in here. Hi, everybody. I was a few minutes.
Robert, how are you doing? It's good to see you.
I'm doing very well. Hi, Dr. Kumar.
Hi.
I'm Faisel's co-host on Faisel and Friends. I guess sometimes I'm the friends, and really glad to be here.
Best friend, Robert. You're the best friend.
I'm the best friend. Ooh, that's very special. So one of my favorite topics, and I like to talk about this in the context of not necessarily the ER, but it's something that I think addresses one of the questions here, which is sort of this old historic model of traditional telemedicine, and how sort of continuity is something that is really important in this sort of guise of treat 'em and street 'em. We want that continuity of care with that PCP to make sure that that patient is getting sort of longitudinal healthcare sort of expertise and healthcare guidance along their life and along their care journey, particularly for patients with chronic illness. With traditional telemedicine, like the Teledocs of the world, like the Amwells of the world, back in 2006, when they really started to grow, you were routed to a new physician every time you signed up for a consultation. So traditional telemedicine, particularly direct-to-consumer telemedicine, has not been really a good primary care setting. It's really just been for sort of like sinus infections and those sort of low severity acute care conditions. But now, especially in my world, what we're starting to see and what we saw at JP Morgan with Teledoc's presentation is it's all about chronic conditions now. It's all about longitudinal virtual care. And so what we're coming back to is this idea of what Faisel always talks about is sort of the doctor-patient relationship and that therapeutic relationship, which is very important, but making sure that there's continuity along the lifespan, which is what you really get from that primary care provider. So whether it's at the emergency department, which is, again, that sort of one-time episodic piece of care, or if it's through sort of a direct-to-consumer telemedicine product, you lose out on that. Okay, I have a record, I'm tracking this patient, I'm helping the patient and coaching them along with their behavior change, I'm helping make sure that I know this patient and their med list, and I have the records on hand to see what's been going on with the patient for a long time. And that's all very, very important. And I think with some of these new telemedicine models that might also be very transactional, that's what concerns me. Are we just building sort of a digital treat 'em and street 'em approach? So I think of like those telemedicine kind of combined direct-to-consumer pharmacy companies, where you're going to go on there, you type in, I want this drug, and then the doctor says, oh, I'll send you this drug, basically. That's kind of the same thing like with the treat 'em and street 'em idea, which is, we're just going to transaction medicine rather than saying this needs to be holistic.
Yeah.
So Robert, to your point, it's interesting you say that, because I've often gotten to discussions with no longer in the ER, but sometimes even in the ER, I ended up becoming their primary care doctor in the ER. And I said, this is not a good utilization of services. Let me get you someone that actually has time to sit down with you to kind of address your social determinants of health and everything like that. Now working on the primary care side, I'm working in an organization that actually supports a lot of those things. I have a smaller amount of patients. I see my patients every day. When I do telehealth, it's to augment what I already do right now. Yeah. And it's been very, very, very beneficial in this regard. They treat me and they work with me like I'm in urgent care ER at the same time too. So while I'm following them in a continuity, right, building that establishment, that relationship, our relationship has actually deepened further to the help of telehealth services.
Yeah.
So my patients text me. They send me FaceTime videos. They send me all sorts of things because care doesn't happen between 7:30 and 5 o'clock. Care happens after those times, actually. So it's not unusual to get a text from a patient at 8, 9 o'clock, sometimes 11 o'clock, and that's okay because I have a smaller panel of patients and I'm able to text them back, or they send me a picture and I can prescribe them a medication based on the pictures that they sent. And I am doing the same thing in that process that I would do in the ER or urgent care. That is actually mixing primary care, urgent care, ER care services all at the same time. And I can see them the next day and give them IV antibiotics if need be in the system of care that I work at. And to me, that's really fabulous because that solves the access to care issue, the convenience to care issue that we're talking about. But the issue is we need to have that same model of care across Medicaid and all across the commercial insurance payers at the same time.
Absolutely. Yeah. And, I think people always get caught up with thinking about telemedicine as like these big companies, right? But like when you use it as sort of a traditional PCP provider, you're just kind of continuing that relationship. And Faisel always talks about how it can actually deepen the relationship. But what it really does is it produces more engaged patients, because I might be willing to come see you every couple of months in person and like get on the bus and go over there to wait in the waiting room for a while. But maybe I'm willing to also talk to you about my health, every month if I do so virtually in my living room. And that has tangible patient benefit. We know that more engaged patients that have that high touch primary care actually have better outcomes. And, part of the big barrier to patients actually getting that type of care is just like, I have a life and, I have a job and I have stuff to do, and going to sit in a waiting room is not a part of that. But do I have 15, 20 minutes in my living room while I'm making dinner? Yeah, I do.
It's actually funny you say that. I've had telehealth visits and I had to tell my patients, look, you can't be driving and doing telehealth visits with me. You got to pull over the side of the road.
Stop.
And please don't do telehealth visits in a public area. Okay. Go to a local place if you really want to show me something. So, patients are excited about this. They know they can get you like that. And the fact that you're available and accessible is really cool to them. And they really do appreciate that, because they say to me, Dr. Kumar, thank you for answering this. I wouldn't have gone to the ER urgent care, which means what? We actually save them thousands of dollars. When it comes to dollars, I'll give you one more bit of data here. The Consumer Health Ratings had a medical expenditure panel called a MEPS panel. In 2017, Florida, for adult women, the low acuity mean charge was $1,456. High acuity average in 2017 charge for men was $7,824. Wow. $10,444 for abdominal pain visit to the ER, $5,722 for back pain, $5,000 for a sprain, $3,000 for upper respiratory infection, and $7,400 for a UTI. I mean, that's just astronomically, and it's absolutely insane. When you talk about seniors in this, their median annual expenditures is $4,200 per person. In $2020, it's about $5,500, and an inpatient room averaged around $4,000 a day. In $2020, it's about $4,500 a day. ER costs about $884. And you're talking about an older population doing these services versus, hey, can I just call you on the phone kind of deal, or can I just text you, or can I just do some quick FaceTime or some secure messaging app to do this kind of stuff? These are folks that have fixed incomes. They don't have money to burn like this. And this is really making a difference in our patients' lives, doing things like this.
So, Ajoy, I was going to ask you one of the questions in the chat, but I got to follow up on what you were saying first, because you said earlier that social inequities drive people to the emergency room. Yep. But you're just telling me that people are spending $7,000 for something that could be treated in the outpatient arena for $200. So
now, what I'm saying is,
how in a society like ours does that happen? I mean,
so they're really not spending it, right? So what's happening? They think they're spending it, but they're actually being driven into bankruptcy by doing these things. Yeah. Medical bankruptcy is the #1 cause for bankruptcy in the United States right now. Yeah. Yes, we say they're paying for it, but they're really not paying for it. They're taking a hit on the chin. If not, society's taking the hit on the chin for them as well, too.
Right.
So this is a big problem. And doing these kind of services, telehealth incorporated with good primary care that's there for longitudinally, you fix the access issues. You don't have to do the treat 'em business. Well, you kind of do, but you do it within the context of a primary care visit. That's longitudinal, and it actually builds that really wonderful relationship with the physician. And we all know relationships matter.
All right. Yeah. Dr. Dan, I think you have a question you were coming in here to do.
Yeah, I do. I'm sorry. I just had to jump in on that. So we have a question. What are your thoughts on remote patient monitoring and using VR, virtual reality in healthcare? And I'm sure Robert has a thought on this. If nobody
This
else
is what my company does. Here's the thing. I'll separate my company marketing hat, right, and I'll put on my I wrote a book about this hat. Remote patient monitoring is really, really good. There's a lot of clinical evidence and randomized clinical trials that suggest that it really helps patients understand their own health by putting metrics and their ability to gauge their health in their own hands. But it also really helps foster a relationship and connectivity to the care team. So when you have patients that are taking their blood pressure and their PCP can see that information, or a nurse can see that information at the clinic, and the patient can understand it, as well as when something goes wrong, nurse calls or physician calls and says, hey, I saw your blood pressure readings the past 2 days have been really high. Here's what I think we should do. And then that patient then learns what should happen when that happens. So patients improve their self-management behaviors, and then they also improve their relationship with their care team. Now, what's really important is that patients actually express, out of about 18 clinical trials asking patients for their own sort of feelings about RPM programs, they say that, well, I feel safer. I feel like I understand my condition better. I feel like I understand my own health, and their self-efficacy has improved for being able to self-manage their own conditions at home. And so that's really what it does. It's about connecting the providers and the care team to the patient, as well as equipping patients to manage their own health rather than waiting for the clinic to tell them how they're doing. And so I'm a big fan of it. I don't know as much about VR. I know they do it a lot for like pediatric patients, so that they can understand what it's like to go into a CT scan. So there's a lot of satisfaction benefits from it. And then they're also using it for patient education for like how to take your insulin pen, so it can walk patients through the experience and work really well there. And then there's some actual like therapeutic benefits. I think they're trying it for like PTSD as well in some circumstances. But I'll get off my soapbox and let Dr. Kumar chat about it.
I agree, Robert. The value is there. The value proposition is there. The business sense is there. And there are use cases there. But there's two things that we have to really be mindful of when we're, this is a new shiny thing that we could have, right? Mm-hmm. Number one, patient health literacy associated with technology literacy. And number two, the affordability of 5G connectivity. Okay. We all know what happened this past year, right? You cannot have the same internet rates anymore, right? So that deal was taken away. So internet's going to become more expensive. So when you're talking about areas that this is really designed for, which is remote locations, some of these people may not be able to afford that without federal grants to go after these kind of things right here. And it's super important. It's very, very helpful. DoD does this all the time through the VA system. All the time they've done this kind of stuff. And it works really, really well. They do this combat medicine and all these kind of things. But when it comes to the private side of healthcare, what insurance companies I think will need to do, along with other partners, is help bring the cost down related to 5G. That's the data transmission rate, and provide some level of services in terms of education and training on how to use these technologies for those that may not know how to read, can't see very well, all those kind of things like that. Because as you know, as we age, vision goes, hearing goes, tactile touch goes, all these things matter, especially when you're communicating. So it works wonders within the population, probably between age, 14. Heck, my kid, he knows how to use my phone. Age 4 to probably age 55 really well. But you have to adapt the technologies to the changing body and what happens to you as you age. And I think those are two very important things we have to keep in mind.
Absolutely. Yeah, so Medicare is the best, most consistent reimbursement. So our program is built for older adults, which had been optimized. And we use Wi-Fi, we don't use 5G. So we try to actually get around those barriers in particular. And then we actually have human being clinicians that are coaches for our patients when they get prescribed and enrolled in our program, so that they can teach them how to do it. And everything's really built for that older adult. Big screens, not a lot of complexity, and easy to use one-time setups for the blood pressure monitors, for example.
And those are the things that you have to do. In fact, there's I would have to say, look at the space program. Look at all the things that they're doing in terms of telehealth, right? If we're going to send people to Mars, imagine the amount of telehealth they're going to have to overcome in order to do that, especially with the time delay, right? In terms of transmission. So you most certainly will be seeing technologies that's being used for the space program in commercial use within the next 20 years, if not accelerated with the use of technology.
So will Elon Musk figure out a way to get free internet for everyone? Do you think, is that what you're saying?
Actually, he has a satellite system that he has called Starlink, right? And so he actually developed a satellite system that they put up out in space, obviously, through their partners and everything like that, to get the satellites out there so they could provide services and compete directly with cable and other subscribers. That's coming.
I would like to see free internet for one, but I think that would do a lot of good for humankind in general, and I think it would do a lot of good for healthcare. So there's a section in my book about how access to broadband internet is actually one of the bigger barriers to telehealth. It's improving, and during COVID, there's a lot of federal money through the FCC poured into it for a lot of rural facilities to set up more broadband, to buy devices. But there's a lot of work that can definitely be done. And you're totally right. 14 to 55 is really that core group. And it's just about getting it into Medicaid payment reimbursements, which some states have done, Virginia, for example. But there's a lot more work to be done in that space, and a lot more science that needs to come out about what works, how you implement it, how best to educate patients on it. So still in the early days.
I agree. I think you're going to see a lot of movement, and I'm hopeful for it in this administration here, because I think they're very forward thinking in terms of technologies that they would have to adapt and utilize for a growing population. Again, 10,000 people a day are entering Medicare. 10,000 people a day.
Oh, yeah. Yep.
I have one comment for the doctors who are concerned about post-COVID primary care life with us preferring telemedicine, specifically towards Melanie. I don't want you to think of it that, that the doctor-patient relationship is somehow going to get lost. The art of the physical exam will get lost. What Robert and Dr. Ajoy were talking about earlier, that when we think about, there's primary care, which is like this urgent care sort of system that we see in fee-for-service. Doctors are just in one shift churning through 25, 30, 35 patients in a shift. Actually, I know a primary care doctor who sees 50 patients every day. And then there's true primary care, where the doctor has that relationship with the patient. And rather than thinking about telemedicine as replacing the doctor-patient relationship, I want people to think of it as an extension of that. For those who can find convenience, like what Robert was saying, like making that time, it's so easy to be able to just pop up and get in touch with your doctor, and especially if it's the same doctor that you're maintaining that relationship with. When I think about conditions like diabetes, for 330 million people, when you're talking about pre-diabetes and diabetes, now we've crossed 100 million Americans who have pre or they're diabetic. And when I think about most of the diabetic care, especially when we're talking about lifestyle modification and we're talking about, with diet and things that they can do, custom tailored treatments that we can offer for patients, most of that can be done in this virtual manner. And the same thing goes with things like when we're talking, now we got almost half of Americans, like 140 million Americans have cardiovascular disease, primarily led by hypertension. But don't you think with the technology that we have available that we can manage most of that in this manner, especially for those people who choose to have that? I understand the fear. I understand the fear that, oh my God, doctors aren't going to be touching patients, and that's a legitimate concern to have. But let me try to assure you that technology and telemedicine especially is not there to replace the doctor-patient relationship. I mean, I think if anything we've seen over the last year, we're all desperate to go back. I'm halfway there. In a couple of weeks, I'm going to have my second shot, and we're going to be getting closer towards normalcy. But I think that it has shown us that it can be a legitimate and very viable extension of the doctor-patient relationship.
Faisel, I'd have to agree upon that there. Having used telehealth extensively, it doesn't compare to having a patient in front of you. And I think it's going to depend on your demographic. Okay. Sometimes the younger folks prefer, hey, a quick digital visit. Okay. We're good with that. Some of the healthier, more senior folks will prefer a quick digital visit. But if you got real issues going on, there is no way in the world that individual is going to sit there and say, let's do it all through telehealth. they're going to want to spend some face-to-face, in-person time with them. And doctors were going to have to accommodate to that. So I have zero fear of that interaction, that in-person, face-to-face interaction is going to go away because of telehealth. I think to Dr. Faisel's standpoint, it's just going to augment the care that we already provide and may actually accelerate certain levels of care as well too. I have patients that say, listen, I'm pretty healthy. I don't need to be seen all the time. I agree with you. Your numbers prove that you are actually pretty healthy. So how about we just touch base real quick, 5 minutes, telehealth, once a month, every other month. Good for me, doc. Sounds like a plan. That kind of stuff works because you still have that frequent touch points. You're still making sure that the patient's doing okay, even when they're healthy, and keeping them healthy that way. And patients are absolutely engaged in the healthcare. I think that is the most important thing. Or I think that what we've seen during COVID, or people, and slightly before COVID actually, or people are starting to see the cost of healthcare and are starting to sit there and say, you know what? I'd rather do this on my own. Let me try to live a healthier lifestyle. Let me start doing all these things. Now, I know Dr. Weiss there, Sandy Weiss, I saw her comment there. I worked with her before as well too. She's right. Until the community has easy and expensive care to healthcare, people will use the ED for basic care. But we have to change that. We have to change that dynamic there. And we can't do it by ourselves. We have to do it through our business partners in order to do that. Yeah.
And it also requires some policy work if we're going to continue to actually make sure that people have coverage and they have access to care. Absolutely essential. And yeah, I'm a big proponent. I'm a big proponent of virtual care and telehealth, but I am also very much somebody who looks to the future in a very realistic way. And there's going to just be a mix of services. Some people will need to be in person. Some things can be done virtually and with higher satisfaction and with similar efficacy. So I'm excited to see where things go. But a lot of this happens at the individual clinical level, at the individual physician level, at the patient level. But a lot of the changes, particularly with access and coverage, needs to come from higher levels, including policy and legislation. And hopefully with a new administration, we're going to see some hopeful good healthcare policies that come out, because we've really been lacking in healthcare leadership over the past several years.
I think that's really important. But I think what I also want to caution our viewers and actually probably give them a reason to do something in terms of being involved in healthcare in their community. There's national policy and there's state policy. Where you make a bigger difference is state policy. The national system sets a benchmark, a framework, and all those kind of things. Some go down to the local level, but where you're going to get your biggest bang for your dollar really is at the local level, at the state level. So those of you that are on this call listening, get involved in your healthcare in your state. This will make a tremendous impact on you. When we talk about treat 'em, street 'em, emergency docs don't like doing it either. They really don't. They want to see the really sick folks. I mean, that's what they went into training for. They don't want to see a sinusitis. I'll tell you, it drove me absolutely nuts one day. Excuse me, when I saw a patient pull up in a ambulance, they delivered him off. What's the emergency? He had a sinusitis. No, what's the emergency? He had a sinusitis. Really? You know how much that ambulance cost the county? About $500, $600.
Yeah.
Yep. By itself. And then the emergency care, $2,000, boom. So all of a sudden, that sinusitis that could be treated in an outpatient setting for less than $100 is now quadruple, probably 10 times the cost that you would care. ER docs don't want to manage these kind of things. Yeah, it's bread and butter kind of stuff, but they really prefer managing the more sicker patients. That's what they went into ER medicine for.
Well, great conversation. Thank you, Dr. Ajoy Kumar. Thank you so much for joining and shedding light.
My pleasure.
This was great. This was great. A lot of great facts, a lot of great data. Robert, you are the best friend. You are the best friend. Thank you so much for coming. I know you're busy. I know you got a lot going on. I just appreciate you coming.
Yeah, glad to be here. Excited about it, as always.
Thank you very much for the opportunity.
Dr. Dan, thank you so much for manning the chat. We had some great comments. I wanted to thank the people who participated in the chat. Thank you for joining us and listening. We're really appreciative of you taking your time on your Thursday evenings to join us. We're really passionate, obviously, about primary care. We're passionate about restoring the doctor-patient relationship. And for any more information about today's topic and to explore opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.